Dear distinguished speakers, APASL members, colleagues, and friends around the world, welcome to the APASL School of Hepatology e-learning platform. This year, the COVID-19 pandemic had changed the world, and many countries are still fighting with the virus, thanks to hard working for all healthcare workers. However, the COVID-19 will not compromise hepatology knowledge. We can learn, interact, and share. Thanks to the guidance of Professor Shiv Sarin for the chairs of steering committees of the APASL, we are now launching the APASL School of Hepatology, where young hepatologists and fellows around the world can update and exchange knowledge. We are now back to the basic to learn important physical findings in hepatology, and we also honor that there are several world-renowned hepatologists and also ophthalmologists in our program. I hope that this program will be beneficial to everyone who attends. Please do not hesitate to ask your questions to the speakers by typing in the chat box. Lastly, I would like to thank all distinguished speakers for being our part of the program and all attendees who joined this webinar today. Thanks, and let me introduce the first speaker, Professor Amitava. Professor Amitava is an ophthalmologist. He is a product of the Armed Forces Medical College, and he's now faculty of JN Medical College, Aligarh Muslim University since 1995. Since he is ophthalmologist, so he's going to touch upon how and what to look for the eyes examination in liver disease. Professor Amitava, please.
Thank you, sir. I'll now share my screen. Okay, is my screen visible? Should I start?
Yes, please.
Okay. Good evening. I am slightly overwhelmed to be addressing such an august gatherings of people who are super specialists by my standards. But let's see what we can cover it between the eye and the liver. I have no financial interest, no any conflict of interest. But before we go to the how and what about the hepatologist, how they're going to go about it, let's see why the hepatologist should be interested in the ocular features. And there are two good reasons for that. One is because it will help to narrow down and quickly come to a diagnosis. And the second is to monitor therapy by looking at the visual features. What one needs is good illumination, magnification, often provided with equipments. But most importantly is passion. If you're passionate about looking for things, you'll find them. We'll be concentrating largely on the slit lamp biomicroscope, but we'll also have a look at some of the ophthalmoscopes which are available. We'll have a look at the smartphones now, which are ubiquitous, and how we can use them to record findings. Our approach will be from out to in, that means from the skin back into the fundus. And we'll look at the recent advances about the ocular coherence tomography of the anterior segment and the high resolution pentacam now being used to identify and quantify KF rings. Now that's the slit lamp on your right, and basically it's just a microscope which has been turned around by 90 degrees. So instead of having the slide down below, you have the eye which is in front. You can rotate the visual apparatus and the slit projector around this common vertical axis, so it swivels around there. And there is a joystick down below where you can move the entire assembly closer to the eye, away from the eye, and from left to right, so you can scan it. Now you can, right from the cornea, see up to the anterior vitreous. What you can't see is the corner of the anterior chamber. For that, you need these gonio lenses that's on the left. And you can see they've got multiple mirrors. So one is for the corner of the anterior chamber, one is to see behind the iris in the extreme periphery. The third is for the mid periphery, and the lens in the middle is for the posterior pole. And this is the 90 diopter lens here. That is also for the posterior pole. And this is how we can see that the slit lamp is being used by the examiner and the examinee now in the corona times. And down below is a younger cousin, that is the portable slit lamp. A lot of companies are manufacturing it. Has the advantage of being used in cases of people who cannot go to a slit lamp. So maybe little children who you sedated for some other reason, it's a good opportunity to use the handheld slit lamp. Or maybe in cases of hepatic coma, you can perhaps use this equipment. On the right, you can see the indirect ophthalmoscope, and now it is battery mounted, so you no more have wires being plugged into the wall somewhere, and it doesn't trip you also. But the important thing is this 20 diopter lens, or even pan lens, but they're essentially strong convex lenses which are used. And most of you will be familiar with the direct ophthalmoscope. And don't forget, it's not just a magnifying device for the anterior segment. It helps to see the fundus. And it's also a refractive equipment, because once you dial in the lenses to see a clear image of the fundus, it gives you a fairly good estimate of the refractive error. And extremely portable too. This series of photographs shows you how these handheld smartphones are being used. Like this picture here on the left, you can see the normal slit lamp. All you got to do is hold the camera on the eyepieces and take photographs through the slit lamp. And here, this photograph here, you can see that you can use this camera to view the fundus with a 20 diopter lens. And the picture on the right is showing you what the fundus image can be, and they can be recorded. To tell you a little bit about how you should use the slit lamp, here are a couple of pictures we'll share together. This one shows you, on the left, you can see the diagram. There's a flood of light, so this diffuse illumination, usually at about 45 degrees angle between the light and the microscope. You can see that in this example, for example, you can see this mutton fat appearance of the pinguicula. So that's something which diffuse illumination can show. And all these vessels, likely that this is inflamed, so it would be a pinguiculitis. The common usage is to form a slit. Now, when you use a slit, especially a vertical one, it cuts across the cornea and it shows the cornea in all its layers. So you can see the tear film, the epithelium, the stroma, the descemet, and the endothelium. And if you go deep inside, you can see the aqueous, the iris, the lens, right up to the anterior. It's like a low power microscope, not at the cellular level, but certainly at the level of the layers. You can also decenter the light from the viewing arm. So you can see this is hitting the iris and bouncing off. And we are watching the one against the darkness of the pupil, and you can see how the corneal precipitates can look in the back scatter. Any opacifications, faint opacification can be picked up with the back scatter. That's retroillumination. The picture shows this rose Bengal red staining, but here again it's a back scatter from the iris, but we are looking against the bright reflex of the iris. On the picture on the right, observe that the pupil is dilated. Here the light is going into the fundus, bouncing off the retina, and coming against that red glow. We can see these faint opacities in the lens. So that's the typical location of the posterior subcapsular cataract, complicated cataract, which you can get in uveitis. You can pick up faint opacifications of the cataract using this retroillumination. In this case, you'll see is a cone has been formed with the light on your right in the diagram. And the focus is in the aqueous, in the anterior chamber. So you can see the background is blurred, the cornea in the foreground is blurred. Is these little dots, if you can make out, they are cells in the anterior chamber. And even fainter would be just a flare in the beam of light. That's the aqueous flare. Those are proteins. And they leak out from blood vessels. That means there is some uveitis, inflammation is going on. The physicists call that flare as a Tyndall effect. And this is another interesting one where an intense beam of light is made to hit the limbus on one side, and then it goes to total internal direction, like in your endoscopes, the light goes in, and it kind of leaks out in the limbus, so you get this halo effect all around. But if there is any opacifications in the cornea, that will throw back the light to the observer. You can see in this case, cornea verticillata, as sometimes found in Fabry's disease and in some toxicity like imidazole. Any corneal opacification, even cloudy corneas, can be picked up with the sclerotic scatter. So now coming to what you really need to see is one common thing on the skin is, of course, these antheliasmas, which are cholesterol bumps formed of foamy histiocytes and macrophages, which are laden with lipids. But this is not always pathognomic, but is found in long-standing cholestasis, in 70% of primary biliary cholangitis and hyperproteinemias, and is known to regress, following liver transplants sometimes. This is, of course, conjunctival icterus. You can see how yellow it looks. It's named after a bird, interestingly. The important thing is that usually it's found when the levels are above 2 mg% in the blood. And in dark-skinned people, which a lot of Indians are dark-skinned, this is the preferable place to look and under natural light. But if you do find icterus with bleeds, you should be suspecting leptospirosis or Weil's disease, and it's a good idea to ask for contact with animals, particularly rodents. And of course, this is the case of dry eyes, found biliary cholangitis and autoimmune hepatitis, amongst others. It might appear like a piece of foam stuck there because of the associated bacteria called Corynebacterium xerosis, which produces gas. It may look like this brown pigmentation temporarily, dry patch, the bite spot, and sometimes the eyeliners or kajal can get stuck up there, and it's called the kajal sign. Apart from the lusterless cornea and other features which you can pick up in the dry eyes, also called keratoconjunctivitis sicca. This is, of course, Gaucher's features, as they are pinguicular on the left, but other features, just to complete this, is the glaucomatous cupping. So you can see this large cup and the pre-retinal deposits, which can be seen on the fundus. You need to use the ophthalmoscope for this, and the slit lamp could be preferred for the picture on the left. We're going to spend some time with the KF rings and Wilson's disease, and see, if it's an obvious one, as in the inset shows, you can perhaps even see it with the naked eye or with some minimal magnification of the loop. But the classic way to see it is with a vertical slit, and if you broaden the slit a little bit, so where the arrowhead is, that's where you see, that's where the endothelium is. This front part is actually the epithelium. So you got to see on this back, the back slit that is part of the slit. That's where that you can see that brownish pigmentation. That's the place where the copper deposits. And it's more common in the vertical meridian. It's 12 o'clock compared to 6 more before it expands horizontally. On the right is, of course, the sunflower cataract, and you can see it metallic appearance to it. This is, of course, a very extensive one. There are other conditions like bilirubin. The picture on the right is again very similar, and that's where the black arrow is. That's bilirubin. Again, a brownish ring there, a pigmentation there in the decimal endothelium there. One on the left is the KF ring. That's part of Wilson. And so there was a report 5 years ago in cases, 40 adults of primary biliary cholangitis with sclerosing cholangitis, where the total bilirubin did 20 mg%, and they had hepatitis for 6 weeks. 37 of those 40 adult patients had this bilirubin-like ring. But once the levels fell below 10 mg%, none of them could be picked up. This one, of course, emphasized, don't look at this bold arrow. I've actually cut them out. I put an X mark. This is the black arrow. The longer one is the one I made. That's again the copper deposits of the KF ring at the back of the cornea. And you can see this one on the right is the same eye. With treatment, you can see it's faded off. So that's where it shows that you can monitor some treatment along by looking at the KF rings. Now, what they did in the anterior segment ocular coherence tomography, you can think of it much like an ultrasound, except with using light instead of sound to create. This top picture on the left is the slit lamp where there is the KF ring seen on the slit lamp. And you can see on the right picture with the red arrow, you can see how that bright black at the back of the cornea, that bright line, that suggests that there's copper deposition there on the ocular coherence tomography. And what these authors did in a paper they published in 2019 in Acta Ophthalmologica, they had 29 cases of Wilson with 29 controls. And they found that none of the controls, they did pick up anything on the slit lamp or the OCT. But like the lower picture shows here on the left, nothing on the slit lamp here in this picture. But yet on the right image, you can see on the OCT, they're getting that whitish line at the back, which indicates that there is copper deposition there. And as they found, 15 cases of Wilson, which were negative for the for KF rings on the slit lamp, were positive for that deposit on the OCT. And this was very significant on McNamara. And they concluded that the anterior segment OCT is pretty superior to slit lamp biomicroscopy, both for diagnosis and monitoring. A very similar outcome was found with the pentacam, the high resolution pentacam. And this was a Danish study, again published last year. There are 31 Wilson cases in Denmark. They divided those Wilson into 3 groups. One with KF rings, there were 10 of them. There were 5 people where there was nothing at all, and there were 16 people they had some lesion in the peripheral cornea, but not a KF ring. And they had another group called the controls. Just let's understand the pictures. The top one is the normal cornea, and this is the inferior aspect. And when the light bounced off, it reflected off the anterior part of the cornea and the posterior part. These are the hills we got. This is the one here on the right is the anterior hill, and this is the posterior hill. So in normal chaps, the reflectance was far more from the anterior side. Look at the bottom picture, the KF ring one. You can see this white patch here at the back, white line, where the copper has deposited. Look at the posterior ring. The hill is much higher. The anterior one is still the same. I must tell you that this is the 100 units here. The 100 unit is here. And in this case, the 100 unit is here. So you can see that the anterior is near the 100 mark. Here also in the lower one, the hill is near the 100 mark. It is the posterior reflection which has really gone up. And in these ones also, the anterior hill is much higher. Now, if you were to do a bit of math and divide this, that means the posterior hill upon the anterior hill height. If you do that, then these two, because the posterior hill is shorter, the fraction would be less than 1. But look at the KF ring. The posterior hill upon the anterior hill would be more than 1. Now, if you can understand that, then we can come here and you can see this is the line of 1, that fraction. And then you can see all the KF rings chaps, most of them are above this line because the posterior reflection was much higher, so the fraction was bigger than 1. Here, no rings at all, some other lesion in the cornea, normal chaps are all below that 1. And this deform was significantly different. And you can see that the area under the curve in the ROC curves is 90%. And that means that it works as a pretty good discriminant. The signal intensity bounce back. This one is, of course, the Alagille syndrome. Basically, the decimates, it ends up in what is called the Schwalbe's line in the angle of the anterior chamber. Now, you can only see it if you use those gonio lenses for the angles. But if the Schwalbe's line becomes prominent and moves anteriorly, it's visible. And that's what you call it, the posterior embryotoxon. That's the kind of this line which is visible. It's marked with an arrow. Sometimes you get peripheral iris abnormalities, which may be part of Exenfeld. Others I've listed below. Uveitis is another important thing that the hepatologist should be interested in. The anisocoria, the irritated pupil always becomes smaller. There would be examination. You may get a KP suggestive of gratis uveitis, corneal deposits on the corneal endothelium here of this, and you can get what is called as a festoon pupils. It's been attempted to it as kind of, and don't forget which can form the ring synecdoche. And there's more on here, something more. You can get keratic precipitates. These are of the granulomatous variety on the cornea. This is again seen against the sclerotic scatter. This is the slit line showing you both the KP deposits on the endothelium. You can see those little, little dots, stony-like thing. This one shows you what is called as a festoon pupil. That means dilatation has been attempted, but where it's stuck, it's not dilated. Where it's not stuck, it has dilated. That's called a festoon pupil. And don't miss out on the pus, which is the hypopion down below, in the severe case of uveitis. And this is to show you the cataract. That's the sunflower cataract, the capsular cataract on the left. And this is the galactosemia, where you get the oil droplet-like appearance against the retroillumination of the fundus. Remember, this too is reversible in the early stages, and it can be used to monitor and control whether dietary advice followed or not. And this is, of course, in some cases of hunters, you don't get too much of corneal pathology, but you get pigmentary retinopathy, very much like retinitis pigmentosa. One may get choked disc in the MPS 6. And this is not following papilledema, mind you. There may be no raised intracranial pressure, but there could be disc swellings. And of course, everybody's keen to know about the cherry red spot, which is surprisingly the normal thing. You see, the deposition is taking place in the ganglion cell, and the fovea is devoid of ganglion cells. It's devoid because it wants, nature wanted light to go straight into the photoreceptors. So there is, therefore now what is people are calling it is called a perifoveal white patch. That's the term they're using, because it takes away, because everybody thinks cherry red spot is the abnormal one actually. So these are the common diseases, the Niemann-Pick and the Tay-Sachs. What I haven't covered is some aspects of the neuroophthalmic manifestations, like cranial nerve palsy that I haven't covered up because of shortage of time. The mid-brain syndromes. You can get gaze palsies in Wilson's, particularly vertical palsies, problems of upgaze, the internuclear ulmopia, and nystagmus. And at the end, I'll just leave you with the thought that not only can the liver affect the eye, but remember, eye cancers can spread to the liver. Hepatitis B, at least in the past, is known to be transmitted through corneal transplants. And a lot of steroids, which are given in autoimmune hepatitis and other conditions, can induce both cataracts and glaucoma. Thank you.
Thank you very much, Professor Amitava. So, by the way, while we're waiting for the questions, let me ask you by asking regarding the KF ring. So just asking on behalf of our medical students, is it possible to examine KF ring on the naked eye?
If it is absolutely very obvious, so it would be a very advanced case, maybe nobody's treating it, it can be seen with some magnification. It can appear as a brownish pigment hue on the periphery. But the correct way would be still the slit lamp.
Okay, especially in Asian people where the iris is golden brown. So it's going to be difficult by examining on the naked eye, right? So you need to send to the ophthalmologist to confirm.
Really, because
we have some technical problem.
Yes, I think some connectivity issues are there. Can you?
Can I answer that question while Dr. Amitava is getting back?
Sure, Professor Alam, please.
Yes, so the Wilson's disease KF ring should never be said that it is not present unless and until you have done a slit lamp examination on whichever eye it may be, maybe an Asian eye or a European eye, but the slit lamp examination should be is a must before you say that this KF ring is not present.
Thank you. So that's the answer for our medical students. I think we can go back to the Q&A after without further ado. So I will introduce the next speakers, Professor Seema Alam. She is pediatric hepatologist and head of medical operation department of pediatric hepatology at Institute of Liver and Biliary Science, New Delhi. So there is no other person that can answer the eye size in the children better than her. So let's have Professor Alam to look at eye size in pediatric liver diseases. Professor Alam, please.
Okay, Izumi had actually made me record the whole thing, so it is recorded with her. I'll be sitting here while she can start the recording. Since it got recorded in 19 minutes, I was happy to have it done.
Okay, so then we go back with the Q&A.
At the outset, I'd like to thank this APASL School of Hepatology for giving me a chance to speak on this topic, eye signs in pediatric liver disease. I have no disclosures, no conflict of interest. This paper that I am showing you at the outset itself is a paper on genomic approach to pediatric cataract. The reason why this paper was taken up was because they found that both in the low-income countries as well as in the higher-income countries, there is a huge number of permanent blindness among children happening due to these pediatric cataracts, which are not treated in time, which there is no intervention required. And I think a lot of intervention can come in these pediatric cataracts if we can know the pediatric liver diseases associated with some of them. So hence, link between pediatric liver disease and pediatric cataracts is important to stop this blindness in the childhood blindness in the country, in the world. Another paper, Occurrence and Pattern of Ocular Disease in Children with Cholestatic Liver Disease. This paper, the importance of this paper is that it's not only the common cholestatic liver diseases which have some ocular abnormalities, they also have some other abnormalities which may not allow a good quality of life for the child. Like the best corrected visual acuity was not good in patients with biliary atresia, with Alagills, with alpha-1 antitrypsin. Similarly, they had cataracts, they had esotropia, they had microcornea. Of course, imperadoxon was present in some of them. Nystagmus was present. Optic atrophy and optic neuritis was present in some of them. So to keep regular monitoring of these patients about the ocular anomalies and their vision and their visual field defects should be kept under close monitoring throughout the disease course of the disease is very important. Vitamin A deficiency in cholestatic liver disease, this should never happen. Especially if the child is with you and you have started his treatment, you should monitor very closely and make sure that the supplementation is going in and not allow this blindness to happen. Among the common neonatal cholestasis disorder, biliary atresia, as you can see here, is a very common disorder. And we have now realized that biliary atresia is a disease starting in utero with implications for treatment and diagnosis then. And hence we now are saying that there are certain genetic disorders which are related with biliary atresia because it is starting in utero. And one such genetic disorder is the chromosome 22 aneuploidy, which is called as the cat eye syndrome, where 33% of these children will have a coloboma in the eye, and about 83% will have anal malformations, will have ear malformations, will have heart and kidney malformations as well. The good point about these patients are that they have a very good prognosis if everything is treated in time, and they do not have any neurological or other sequelae, so they can have a very good prognosis. So the only idea is to pick up these patients with these associations and treat them properly. As far as the natural history of Alagille syndrome and the diagnosis of Alagille syndrome is concerned, we all know it is dependent on certain facial features, certain eye features. It's butterfly vertebrae, peripheral stenosis, peripheral pulmonary stenosis, and on the liver biopsy you will find cholestasis as well as bile duct paucity. So with all this, Alagilles can be diagnosed, and as you can see, this is the typical facies that you see: prominent forehead, bulbous nose, pointed chin, low set ears, and depressed nasal bridge in both these children. You can see that they have pruritus, severe pruritus, and xanthelisma if it is not intervened with. And in the last photograph, you can see the butterfly vertebrae in the X-ray. This is all the features. These are all features of Alagilles. If a child is young and he's not showing very clear-cut signs of facial features of Alagilles, you can even see the facial features of the parents, which will give you an idea that this could be an Alagille syndrome. And early intervention of these patients may help out in better quality of life. Ocular anomalies in Alagilles, I would not like to speak much because we know about posterior toxon, which is present in 95%, but there are other anomalies also. Although these children usually have a good visual acuity, and my previous speaker has already talked about the other anomalies. There are certain congenital or neonatal cholestasis because of infectious origin, and this infections come from the intrauterine period, and these are called torch infections, especially congenital CMV. The spectrum may vary from mild non-specific findings to multi-organ involvement finding with hepatosplenomegaly, cholestasis, elevated transaminases, anemia, thrombocytopenia, petechial hemorrhages, encephalitis, and pneumonitis. And all these patients may be having associated ocular anomalies in the anterior segment like cataract, corneal opacity, scars, posterior segment like chorioretinitis, salt pepper retinopathy, glaucoma, optic atrophy, microphthalmia, strabismus, nystagmus. All this, if picked up in time and intervened, may give a good quality of life to the child, as well as maybe save his vision. This is what is a typical salt pepper retinopathy, which we have always read about, associated with rubella and other torch infections. Another condition, which is a transient, not very common condition, causes transient cholestasis, is the congenital hyperpituitarism. It is associated with the cholestasis with low or normal GGT, usually defined as more than 2 pituitary hormones being lower than normal. These children can come with transient cholestasis, hypoglycemia, and microgenitalia in the boys. This is how the micropenis looks like in boys. And this is how they may have the malformations both in the brain as well as in the optic nerve. And this is what is called as septo-optic dysplasia, where the infant is not able to visually fixate and is not able to follow. There's hypoplasia of one or both the optic nerves. There's ventral midline developmental defect, and there is midline facial deformities present in these patients. The good thing is that this can be diagnosed with subnormal cortisol and growth hormone and can be treated with the supplementation of these hormones very soon, very well. So hence it should be picked up early. Recently, some authors at King's College have studied and felt that the cortisol and the thyroxine may be required for the hepatocellular expression of certain canalicular transport proteins, and that can be seen in this, that these BSEP, MDR3, MRP2, and GGT were all low in the histology of the congenital hyperpituitarism. Infantile liver failure is another very common condition for the pediatric hepatologist to tackle. The boxes, the etiologies present in the blue boxes, that is galactosemia, hereditary fructose intolerance, and the mitochondrial disorders, are more likely to have associated ocular anomalies, and that we would take up now. The first one is the classical galactosemia. We know that classical galactosemia is basically is due to the absence of the GALT enzyme, or the galactose-1 phosphate aminotransferase enzyme, which is in the Leloir pathway of galactose metabolism. And if this enzyme is absent, there's accumulation of galactose-1 phosphate, which is a very hepatotoxic or toxic metabolite to have, which can then later on become galactitol or galactonate, and together both these three metabolites, especially galactitol, can cause this oil drop like picture of the eye, giving rise to this oil-like picture. And some authors have studied the assessment of these biochemical assessment of these cataracts have been done, and they have found dulcitol to be present in this, which is actually a metabolite of galactitol. And as the previous author said, it can be prevented very easily if there is a restriction of galactose in the diet of these patients. So picking them early means that you are improving, giving them a life and also giving vision to these children. In hereditary fructose intolerance, which is usually presenting in infancy, like I told you, hypoglycemia, lactic acidosis, ketosis, recurrent vomiting and diarrhea, but usually happens when there is introduction of fructose in the diet of the baby. And if you continue to give fructose to these babies, they may land up with hepatomegaly, with growth retardation, even liver failure. Some of these older children and adults may learn to have a natural aversion to these fruits and sweets which contain fructose, and may have a life with vomiting and hypoglycemia every time they take fructose. So fructosemia or hereditary fructose intolerance happens because of the aldolase enzyme, which causes accumulation of fructose 1-phosphate, which causes the negative feedback and causes hypoglycemia and lactic acidosis, as we all know. And a reported sibling product of consanguineous marriage have been found to have, and more such case reports are there all over the world, to have bilateral cataracts and cirrhosis with very low fructoaldolase in their liver tissue. Lysosomal storage disorders, I will take up only those which have liver involvement. One such thing is sphingolipidosis. The acid sphingomyelinase deficiency, which was formerly known as Niemann-Pick disease type A and B, is because of the accumulation of a sphingomyelin and is happening because of the mutation of the gene SMPD1. It usually presents as either severe infantile variety, which has failure to thrive, hepatosplenomegaly, diarrhea, cholestatic jaundice, right in the infantile period. Then you may have a mild, very mild, chronic, mostly neurological variety with just hepatosplenomegaly, and they usually go on as an insidious onset, and an intermediate variety between the two. The death of these different varieties could be as, the infantile variety may live only up till 3 years. This may live up till childhood to adulthood, and the mild chronic neurovisceral form usually go up to adulthood. They have a common presentation in the eye, that is a macular cherry red spot, or what you call as perifoveal white patch, seen in 1/3 and 100% of those who come to you with the infantile variety. I will let it remain like this. This is the cherry red spot of a perifoveal white patch. The whole idea behind this is that the part which is cherry red spot is actually the normal part. The deposits are happening all around that. The Niemann-Pick C disease, which is two types like NPC1 gene and NPC2 gene, they have a continuum from neonatal type to infants to a classic childhood form. It's the severe form is the neonatal form, like you can see, fetal hydrops, cholestatic jaundice, and liver failure. Some of them may have just organomegaly, hypertonia, and delayed milestones. But they have this characteristic vertical supranuclear gaze palsy, which happens around the second half of the infantile period in almost 100%, initially starting with vertical saccades impaired and later on with the horizontal saccades impaired. And this helps in the diagnosis of these patients, apart from other things. Gaucher's disease, common in Ashkenazi Jews, deficiency of glucocerebrosidase, accumulation of glucosylceramide in the lysosomes of the macrophages. Like the previous talk, we heard that Gaucher's type 1, more than 90% of the Gaucher's is Gaucher's type 1, which is non-neuronopathic, and I will concentrate on this, which has hepatosplenomegaly, thrombocytopenia, anemia, bone pain, and poor growth. They have good visual acuity, but they would have uveitis, they would have pingicular, they would have deposits in the anterior segment. And I would not discuss type 2 and 3 because they're largely neuronopathic. Surgical removal of these deposits may help out in the vision of these patients. The enzyme replacement therapy, which is available for type 1 and type 3, has been known to be very effective in otherwise in the patients, but not in the management of the ocular condition. So we should pick up these conditions even before they become irreversible. Mitochondrial liver disease working group has pointed out that 35% of their total number of cases had ophthalmological abnormalities, and you could pick up these abnormalities and connect them with the type of the mitochondriopathy they may be having. So, and also pick up these abnormalities before they deteriorate the quality of life of these children. Zellweger syndrome, again, an absence of functional peroxisomes in cells. It's a severe disorder, may have even in very mild variety accumulation of the very long chain fatty acid and branch chain fatty acids. They have craniofacial abnormalities, organomegaly, cholestasis, and chondrodysplasias. Ophthalmic manifestations are corneal, cataract, glaucoma, pigmentary retinopathy, and optic atrophy. These are very serious diseases, and in most of them, there are no treatments available. Long-term side effects of glucocorticoid has been discussed by the previous author. Cataracts and glaucomas are common, even with low doses. seems that glucocorticoid-induced gene transcription in lens epithelial cells can generate these steroid cataracts. Systemic glucocorticoids can give rise to increase in the intraocular pressures, which may regress with the cessation of the corticosteroid therapy. Reduced function of the trabecular meshwork could be responsible for this raise in the IOP. Another condition called as primary hyperoxaluria type 1, where you have systemic oxalate depositation causing end-stage renal disease. The enzyme is deficient in the liver, but it causes end-stage liver disease. Usually they need a combined SLK, that is liver as well as kidney transplant. But if you had retinopathy because of deposits of oxalate in the eye, then it is irreversible. So whatever has to happen, if you have to have a liver disease, liver transplant or a kidney transplant or a combined transplant, you must do it before this retinopathy happens so that the visual deterioration does not occur. There's been seen that post-transplant lymphoproliferative disorders are now also seen to be associated with ocular PTLD, and these are seen as mutton fat KPs, keratic precipitates, and they seem to clear up completely once you stop immunosuppressants, which is the treatment for PTLD. Now, just 1 or 2 slides about the prevalence of K-Fring in hepatic Wilson's disease. It is known that only 50% of the 50 to 60% of the K-Frings of the hepatic Wilson's have K-Frings, although in our own study we found 80% of our patients with ACLF and DCLD had K-Fring present. Similarly, in a South Indian study, ALF patients, 89% of them had K-Fring present. What could be the reason? We have hypothesized that maybe it's the mutations which are present in our subcontinent, which cause long-standing cirrhosis in these patients or due to copper toxicity, and they get unmasked by the acute precipitating event which happens. So hence the K-Fring prevalence is very high in these children. Another small study, changes in optic nerve sheath diameter can be used in the management of intracranial hypertension and pediatric acute liver failure. This can be measured with a B scan at the level of the optic head, just 3 millimeters behind this, and you'll see the nerve sheath diameter. What we found was that the 4.4 millimeter diameter was the best cutoff to accurately diagnose raised ICT with the accuracy of 96.2%. And we also felt that it is not only picking up the raised ICT, it's also picking up the improvement 2 hours after the management of that event of raised ICT. And it is, significantly improved ONSD just after 2 hours after the management of that event. So we feel that ONSD is a very good addition in the monitoring of these patients. I conclude, diagnostic hints for early diagnosis, especially coming from the treatable disorders through the ocular anomalies, are a very good, monitoring or a very good diagnostic tool for pediatric hepatologists in pediatric liver diseases. These ocular anomalies may present anytime early or late in the disease of the course, so the monitoring should carry on in these patients. And monitoring for other ocular anomalies from what you have seen in the beginning should also carry on. Close monitoring is very much required to improve the quality of life, because these ocular findings may affect the vision as well as impact the outcome of these patients pre-transplant and post-transplant. Thank you.
Thank you very much, Professor Alam, for your extensive coverage on the eye on pediatric patients. There are several questions on the webinar. I hope that Professor Amitava, you are back. So let me start asking.
I'm back in action, yes.
Okay, by asking Professor Alam first. There is a question about how to manage cataract in galactosemia. When you can wait?
I think I think Dr. Amitava also mentioned that if you start management of galactosemia, in the initial part itself, these cataracts usually come within the first month or first 2 weeks of life, just after first 2 weeks of life. So what is seen is that once you've diagnosed a galactosemia, if you restrict the galactose diet, they tend to resolve themselves and go away. Most of these cataracts usually go away, and you do not need to really take them out. But maybe more advanced patient where the cataract is not resolving may require some kind of surgical management of those cataracts. Although we haven't seen a surgical management in all these years, we usually see them resolve on their own.
Okay. There is a question by Professor Sarin to Professor Amitava. So so what is the best questions for and test for dry eye in autoimmune liver diseases?
I know. I noticed that it's not. It's a very interesting question, and it's not going to be easy to answer that, because at the bedside, because you see, this dry eye is a very vague symptomatology. All sorts of people can complain of dry eyes. Usually there are people who are sitting in air-conditioned atmospheres and such things. But if you have a background disease where dry eyes is associated, and if he's having some issues about vision, then only an examination can suggest. That means you're seeing a lot of debris in the aqueous, in the tears. You can see a lusterless cornea, a Bitot spot, or some test that you do like breakup time or the Schirmer's test to see the wetting. They will be more helpful than asking questions. It's very difficult to have questions helping you diagnose dry eyes. It's a pretty vague topic, even in ophthalmology.
And how about how to diagnose pseudo-ophthalmos in alcoholic liver disease?
I find that a very challenging question for me, because I think
always because
alcoholic
patients.
Yes, and the alcoholics who reach us are those who've injured their eyes. They really, but anything which is not an exophthalmos and looks like one is likely to have lid retraction, and an eye which appears more exposed but not protruding forward. So the trick is basically to have a side view. Is the eye really protruding out of the globe? That is exophthalmos. Otherwise, lid retraction can make it appear like that. That would be a pseudo-exophthalmos.
And my last question before I pass my microphone to Professor Sarin, is K-ring still present in post-liver transplantation in the patient with Wilson disease?
Do you want me to answer this? Do you want me to answer this?
Okay, both of you, please.
Okay, so my answer to this is that mostly we do not really go around asking for a slit lamp examination after liver transplant. We haven't really done that, because actually these patients usually improve on their own. So unless and until we have done a slit lamp examination on these patients, we cannot say the K-ring is not present. But in few of them where the K-ring was present otherwise, even on a torchlight, I've seen it regress on its own.
Thank you so much. Thank you. Do you have any comment on that, Professor Amitava?
Yes, I would just say that, most of my medicine colleagues or pediatric colleagues do not refer most of their cases to the ophthalmologist. That's one thing. You had a question whether we could see it against the brown iris, the K-ring. And that's when my communication went for a 6. But the point is, because you're seeing it in magnification and in depth, so iris is further behind the cornea. So the pigmentation of the iris, the color of the iris doesn't confuse people at the slit lamp, because you can see the depth. The picture is in depth. So you are focusing bang on the endothelium and the descemet. That's where the pigmentation is. It doesn't confuse you with the pigmentation of the brown iris at the back.
But how about examination on the on the bedside without slit lamp?
Yes, that wouldn't be a good idea. That can confuse people, because you see, it's difficult to pick up faint rings in any case, and one can get a little confused with the pigmentation. Slit lamp is the way to go. That's the gold standard so far.
Thank you so much. Thank you for extensive talk for both of you. So then now I will pass my role to Professor Shiv Sarin, Chair of the APASL Steering Committee. Professor Sarin, please.
Thank you.
you, Professor Tanwandee, and thanks to both the speakers for their excellent presentations. Just for brief, we have more than 400 people logged in and 600 registered. I was hoping to see Professor Omata, unless he has gone back to work. Is Professor Omata there?
I'm here. I'm listening.
Maybe Professor Omata is one of our senior members.
On exotic diseases to me. So I'm becoming a student for the speakers. Thanks a lot.
May you kindly introduce the next two speakers, please, Professor Omata. Yeah.
Well, the Bernstein, Dr. Bernstein is the head of the liver subspecialty service line and vice chair of clinical trials, chief division hepatology, Sandra Trust Bus Center for liver disease for the Northwell Health System. And he's a professor of medicine science at the Zucker School, medicine at Hofstra Northwell. So today he may touch on the problem, so oral and cutaneous signs in liver disease. David Bernstein, please.
Hello, my name is David Bernstein. I am talking to you from the Northwell Health System in New York. And what I would like to cover in this lecture are the oral and cutaneous signs that are seen in people with liver disease. As we know, there are many liver diseases, and while they are liver diseases, many of these conditions are associated with many extrahepatic manifestations. Commonly, liver diseases are associated with both oral and cutaneous findings. And because of this, it's very important that we should be aware of what these findings are. So when we're seeing a patient and performing a physical examination, we know both what we're looking for and also remember how important it is to examine both the oral cavity and the skin in our patients. Many times we focus just on the chest and the abdomen to evaluate the liver, but forget or neglect how important it is to examine the whole body, since most liver conditions can be systemic. If we talk then about some of the oral manifestations that can be seen in liver dysfunction, and this is regardless of what the etiology is, meaning any patient with liver disease can present with these types of complaints. And if we focus on the mouth, we can certainly see patients that have bleeding gums, right? Not related to bad gum disease, although that certainly can be seen in patients with alcoholic liver disease, but because they may have low platelets or they may have a prolonged INR, which causes them to have much more friable gums and then bleed. Looking in the mouth, we can see the mucous membranes, which can be jaundiced. When you get close to the mouth, you may be able to smell what's called fetor hepaticus. Here, the breath has a musty smell that's really quite distinctive and generally related to the fact that the liver isn't working well and that the liver isn't able to take out some of the toxins. And some of those toxins that may be circulating in the blood include dimethyl sulfide, acetone, 2-butanone, or 2-pentanone. So important to actually smell the patient's breath. You may see what's called colitis or inflammation of the lips, which again related to liver dysfunction. There can be a smooth tongue. Many of the patients will have xerostomia or dry mouth, and we're going to come back to that. Patients with advanced liver disease can develop what's called bruxism. It's a teeth grinding or jaw clenching that's seen in particular in these patients with liver disease. They can develop perioral rashes, so rashes seen around the mouth, which tend to crust. In those patients that have significant thrombocytopenia, low platelets. You can see petechiae in the mouth, and it's important to look for that. And in the patients that are on immunosuppression or maybe immunocompromised with liver disease, we still are seeing patients that have candidiasis. So it's very important to look in the mouth and look in the hypopharynx, as these manifestations can occur in patients with liver disease. If we look specifically then to certain conditions, and alcoholic liver disease being one of the most common causes of advanced liver disease across the world, there are several conditions that are associated with alcoholic liver disease in the mouth. Glossitis is one, angle cheilitis, gingivitis, a smooth or atrophic tongue, and sialadenosis. And so what are these? Really, how do we define these? So glossitis is an inflammation of the tongue. You look in and this tongue looks large and swollen. Angle cheilitis is inflammation in the corners of the mouth. Very distinctive, very painful, and many times these patients will present to the dentist with these complaints. Gingivitis, inflammation of the gums, many times related to poor dentition, and then with the gingivitis, the patients brush their teeth, you can see bleeding, and then you have gum bleeding. The smooth or atrophic tongue are related to poor nutrition, and here we see vitamin B12 deficiency, so it's important in these patients with chronic liver disease to assess for vitamin B12. And then sialadenosis, which is an enlargement of the salivary glands, usually the parotid glands with adipose tissue. And they look like chipmunks, if you will, or squirrels. And I'm going to show you a couple of pictures now of what these findings are in the mouth. So this here is angular cheilitis, and you can see where the arrows are that in this person, there's significant inflammation really right there in the corners. It can lead to cracking, which can lead to significant discomfort, and these can also become superinfected. Sialenitis here you can see in this gentleman, and you can see that his parotid glands are big and swollen with adipose tissue. These are non-tender, so it's not as though there is an infection there, but this is related to fat deposition. So these are soft, they feel like a lipoma, but this is important for you to look at and know that this is associated with patients with alcoholic liver disease. Hepatitis C is another very common condition which affects the liver, and there are certain oral manifestations of this as well. Now you can see here there's an overlap. Lichen planus is one, which I'll show you a picture of. Going to come back again to xerostomia, dry mouth, all part of the Sjogren syndrome, so dry mouth, dry eyes seen in patients with hepatitis C. And sialenitis that we've already discussed, that's something that one can see in patients with alcoholic liver disease. Here is lichen planus seen on the tongue, and you can see here this is the center of the tongue, and what you can see is this whitish area which tends to be painful, and the cracking that you see, and that is lichen planus in this particular case associated with hepatitis C. So important for you to remember to look at the tongue, have the patient stick the tongue out. Not only do you need to know from a cranial nerve evaluation if it comes out straight, but you need to know if there's something on it, and lichen planus is something that you should be looking for. Remember, the treatment of lichen planus is to treat the hepatitis C. So in a brief summary then of some of the oral manifestations of liver disease, what would be the most common by various conditions? Alcoholic liver disease is bleeding tendency for multiple reasons: low platelets, advanced disease, poor gum care, and the sialenitis. Primary biliary cholangitis we didn't talk about before, but it is also associated with Sjogren, so these patients get dry mouth, and with lichen planus. Hepatitis C the same, lichen planus and Sjogren's. Those patients who are on immunotherapy, so your autoimmune hepatitis patient who is taking Imuran, or your transplant patient who is taking immunosuppression, they're at risk for developing candidiasis. Thrombocytopenia, whatever the cause may be, you can see petechiae in the mouth. And then let's not forget hepatocellular carcinoma, which tends to be mostly in the liver and spread locally to other organs around the vessels, has also been shown to metastasize to the premolar and ramus region of the mandible, the bone, and that also may be able to be picked up when you're doing an oral exam. So you're going to need to feel the jaw and look into the mouth. So those are some of the common findings that we see in liver disease in the mouth and the perioral area. Let's move over to the skin, right? The skin is the biggest organ outside of the body, the liver being the largest organ inside the body. And there are, again, many manifestations of liver disease which affects the skin. Starting with pruritus, is itching, which tends to be not associated with a rash, but pruritus is very common. Patients can become jaundiced. You look at the skin and you're going to see that they're icteric. Spiny angioma, which is mostly seen on the chest, but can be seen anywhere, again, important to look for. Remember, on the chest, up to 5 or 6 spiny angioma are normal, and those patients may not have liver disease. But when you see a lot more, well, that goes along with having advanced liver disease. Patients can develop clubbing of the fingers. They can develop palmar erythema. They can develop Terry's nails, and I will show you some pictures of that. Less common related to portal hypertension, but certainly there is caput medusa, where you see on the abdomen, and you can see the vessels. Patients can develop significant urticaria, mostly related to viral hepatitis, and when we talk about that, it's usually hepatitis A and hepatitis B. And in those patients that have received a liver transplant and are being followed, basal cell skin carcinoma is also common, and these patients need to be examined regularly. If you don't feel comfortable doing that, then they should be seen by a dermatologist at least once a year for evaluation for the development of basal cell skin carcinoma. So here's a nice example of a spider angioma. It tends to be seen in patients who are younger and is associated with an elevated plasma vascular growth factor. Now remember, up to 4 or 5 of these on the chest is normal, but once you start seeing a lot more, then it's associated with liver disease. These are non-tender, they're non-pruritic, and so patients may not notice that they're there until you actually do look for them. Here's a classic example of clubbing. We're used to talking about clubbing in patients that have chronic obstructive pulmonary disease, but here you can see, again, common in those patients with advanced liver disease. So make sure you take a look at those fingers and see what those changes are. While you're with the hands, you should look at the palms and see whether or not the patient has palmar erythema. Right? And again, this doesn't hurt to be associated and related to hormonal changes, but quite common for patients to have palmar erythema. What it looks like is as though if you were sitting on your hands and they turn red, well, that's what you're going to see on the palms of the hands, but the patients don't give you that history. It's related to liver disease. So take that hand in your hand, look at the palm, look for palmar erythema, hold up the fingers, look for clubbing, right? And then while you're there, look at the nails. These are Terry's nails. You can see here that the nails are all white except for the tip where there's a band of pink, and you can see that shown here in the arrow. Terry's nails can be seen in any condition which causes advanced liver disease. So now we've sort of gone over just the hand. We have the palmar erythema, we have the clubbing, and we have looking for Terry's nails. So you can see a lot of skin changes just by looking at the patient's hands. Now let's look at skin manifestations that are related to specific liver diseases. Right? You already know what the disease is. Now you need to know, what you're looking for. Now, mixed cryoglobulinemia, very commonly seen in patients with hepatitis C. And here you can see the rash, which is associated with this. This is on the feet. It tends to be in areas low down, related to gravity, not dissimilar from when you see petechiae as well. But this is a mixed cryoglobulinemia. This is caused by hepatitis C. The treatment of mixed cryoglobulinemia if it's symptomatic and causing renal disease would be plasmapheresis or other therapies. But the underlying treatment to get rid of this is actually to treat and cure the hepatitis C. So look for mixed cryoglobulinemia. Here you can see lichen planus. Before we looked at the tongue. Now we can see it, on the skin. You can see the net-like changes here. And this is known as Wickham striae. And so you have to have a good close look at the skin in patients with hepatitis C as you look for this. Again, the treatment of lichen planus will be to treat the underlying hepatitis C, so it's important to look for. In areas where there are warmer climates, here you can see porphyria cutaneous tartar, again associated with hepatitis C, very dramatic when you see it. We in the United States tend to see it more in warmer climates than in the colder climates. But if you see this again, these patients tend to be iron overloaded. They may have some success with some phlebotomy, but the underlying treatment of this as well is to treat the hepatitis C. So you're going to be spending a lot of time looking at the skin on the hands, as we've already gone over several others. Here, if we look at the feet, this is another far less common skin condition associated with chronic hepatitis C. This is necrolytic acral erythema. It's quite striking when you do see it. And so again, make sure you take off the patient's socks if they're wearing socks. Make sure you take off the patient's slippers if they're wearing slippers, and look for these conditions. Make sure that you really get a good look at the patient's skin, literally from head to toe. This is erythema nodosum. This can be painful. This is associated with hepatitis B. Again, important to look. It's got a classic appearance. And so you should be looking for this as you examine your patients with hepatitis B. Less common is something called Giannetti-Crosty syndrome. These are it's a papular skin reaction related to viral infection, most commonly of the hepatitis viruses seen in hepatitis B, but may also be seen in hepatitis A and in hepatitis C infection. This tends to improve when the viral infection either is cured or the viral infection passes, or the viral infection is under good treatment. And so look for these papules, and again, important to distinguish this, very different looking than erythema nodosum. This is livido racemosa, seen in PAN, polyarteritis nodosa, more commonly seen in hepatitis C and hepatitis B. It's associated also with a vasculitis. This can be quite severe. This requires immediate type therapy. And so important to be able to recognize this livido racemosa. When you do see this, think of PAN, think of viral hepatitis, and treat the patient then accordingly. This is a patient with primary biliary cholangitis. This patient has bilateral xanthelasma, as you can see. Above the eye, the yellowish area is pointed out by the yellow arrows. It's quite striking when you see this. It goes along with primary biliary cholangitis. These findings generally do not go away over time with therapy, so important to look for. And here you can see another patient that has under the eye xanthelasma. This patient also has PBC. So this is a hard finding to miss, but you need to look and be aware. And many of the times the patients will have these findings long before they're diagnosed with PBC. This is a painful condition. This is pyoderma gangrenosum. This is associated with ulcerative colitis and therefore is also associated with primary sclerosing cholangitis, PSC. We're seeing this more and more for unexplained reasons. But again, this is a very important skin finding that you should look for. Most of the time, the patients will tell you, they will notice this and they will come in for care. It tends to be more in the patients that have ulcerative colitis, but again, you're going to see this in your patients with primary sclerosing cholangitis. This is pustular vasculitis associated with primary biliary cholangitis. And you can see here, this can be painful. And again, important to look, make sure you take off the patient's shirt. Make sure you take off to further examine the breast and see whether or not this pustular vasculitis is present. Again, another important skin finding in a patient with PBC. This is a patient that has hemochromatosis. What you can see here is this bronze hyperpigmentation, what is also associated and called bronze diabetes. It's very easy to make this diagnosis. What you simply do is look at the non-sun exposed areas under their underwear, and if it has the same bronze hyperpigmentation that it isn't tan from the sun, it's related to this hemochromatosis. And so this is also very striking when you see this. So again, remember, make sure you put the patient in a gown. This is Dupuytren's contraction. And here you can see typically in alcoholic liver disease. So again, important to look at the hands when you're examining these patients. So in summary, we talked a lot about multiple skin manifestations of liver disease. Overall, the skin is really a window to a patient's general health. And it's very important in patients with liver disease that you do a good skin exam. Most of the findings are common, but generally not specific to that particular liver disease or to liver disease in general, but important to look. And we went over some of the conditions that are more specific to chronic liver disease. But when you see things on the skin and you can't explain them with liver disease, it's important to discuss it with the patient and refer them accordingly. So with that, I'd really like to thank you for your attention, and I hope you enjoyed this overview of oral and skin manifestations of the liver. Thank you very much.
Thank you very much, Dr. Bernstein. Unfortunately, because of time differences, we cannot communicate on live with him. So maybe I have to proceed to the next speaker, Sanjaya Satapathy, and he will also speak on the hair and the nail signs in liver diseases. He is currently an associate professor of medicine at the Zucker School of Medicine at the Hofstra University and serving as a medical director of liver transplantation at the North Shore University Hospital. So, Dr. Satapathy, could you continue on the topics on hair and nail signs in liver diseases, please?
Hello, good morning and good evening, depending on where are you from. I am Sanjaya Satapathy from United States, from North Shore University Hospital. I'm an associate professor of medicine at the Donald and Barbara Zucker School of Medicine in Northwell Health in New York. At the outset, I would like to thank the organizers of the APASL especially Professor Manoj Kumar for the kind invitation, for giving this lecture on hair and nail signs of liver disease. At the outset, I would like to first give an overview of the structure and pathology of the nail. On the left side of this cartoon that I'm presenting on this slide, you can see the anatomic structures of the nail. You see the nail bed underneath the nail plate and the proximal nail fold, and the junction of the nail plate and the proximal nail bed is the hyponychium. In the middle of these cartoons that I'm presenting, you have a more overview picture where you can see the nail plate. At the proximal part of the nail plate, there is a moon-shaped coloration, which is called the lunula. This is an important observation that you have to keep in mind, because a disappearance of the lunula may have pathologic implications. On the both sides of the nail plate, you have the nail folds. And now I will draw your attention to the right side of the picture, where you can see all the different pathologic findings of the nail. You can see pittings, you can see onycholysis, which is the destruction of the nail plate, the longitudinal bends, Bewes line, Mies line, and Marquis line. We'll talk about all this in the following sections as I move forward through this lecture. I would like to divide the nail signs into two different forms. One is the shape and the growth change, and second as the color change of the nails, because the shape and growth change could be a signal for a specific underlying systemic liver disease, so as the colorations or discolorations, I'll say. Most common findings that you see in the nail is the clubbing. That is not specific for cirrhosis, but it is common in cirrhosis patients as well. Aside from cirrhosis, you have a number of other medical conditions as outlined here on this slide that can cause clubbing. For example, inflammatory bowel disease, pulmonary malignancy, asbestosis, chronic bronchitis, COPD, congenital heart disease, endocritis, and so on and so forth. The other signs, other nail signs, are koilonychia, which is a flat sepid nail or spoon sepid nail, shaped nail, where very commonly seen in iron deficiency anemia, but you can also see in hemochromatosis as another chronic liver disease. Many other conditions here outlined, onycholysis, pitting, Bewes line, and yellow nail. We will talk about this in the following sections, but I would like to outline these different etiologies for these conditions. Color change of the nail can also be a sign of underlying liver disease as well as other systemic conditions. Terry's nail or white nail occurs in hepatic failure, cirrhosis, also in diabetes, CHF, hyperthyroidism, and malnutrition. Azure lunula, we'll talk about it, occurs in Wilson's disease. Half and half nails in specific for renal failure, where the half of the nail is white and the half of the nail is at the pinkish colorations. Marquis line, specific for hypoalbuminemia, we'll talk about it. Mies line, dark longitudinal streaks, and the longitudinal striation and splinter hemorrhages could be a clue to underlying systemic illnesses, which may be present in cirrhotic space, in liver disease patients, and may need your attention when you are examining these patients. So coming back to the most common sign of the nail sign in the liver disease is the Terry's nails. Terry's nails is a physical finding in which fingernails and toenails appear white with a characteristic ground glass appearance with a dark bend at the tip and the absence of lunula. So here in the picture you can see on the left side you have Terry's nail, on the middle you have on this cartoon you have the healthy nail. Now, if you compare the healthy nail and the Terry's nail, you can see the lunula, which is the moon-shaped coloration at the bottom of the nail plate, is missing on the Terry's nail side. So you have a ground glass white appearance, and there is a dark bend at the distal tip of the nail, which could be, which is called the Terry's nail. Occurs in aging, type 2 diabetes mellitus, congestive heart failure, chronic renal failure, but most importantly is an important finding in patients with cirrhosis. The pathogenesis of Terry's nail is decrease in vascularity and an increase in connective tissue within the nail bed. Bewes line. Okay, Bewes line, as you can see, there are two different views of the Bewes line in this particular patient. These are caused by temporary disruption of the growth of the proximal nail matrix. What you see is a palpable depression and a non-blanchability. So palpable depression, you can see the lateral view in the figure B, there is a palpable depression. And when you press there is no blanching, and this particular non-blanchability distinguishes this Bewes line from Mies line, which is, and we'll talk about it a little later, and the Marquis line, which is also a white nail, like a white longitudinal, white parallel bands, which may be sometimes confusing. But the most important thing that you have to see is the horizontal ridges with a trough in between, which is typical on the Bewes line. Well, it may not be specific for liver disease, this particular sign, but severe malnutrition is one of the cause, and patients with alcoholic liver disease with periods of malnutrition, patients with febrile illnesses can have, especially in patients with chronic liver disease and cirrhosis, goes through periods of malnutrition, and you can present this kind of findings. Azure linula occurs in Wilson's disease, not specific for it, but it is something or something called as the blue nails, but quite common in this situations, particularly in hepatolenticular degeneration like Wilson's disease, but can be seen in argyria, hemoglobin M disease, and hereditary acrolevial telangiectasias. So these are blue nails, or more formally azure linula, characterized by blue discoloration of the linula. Look at the linula at the bottom of the nail plate. This and this is thought to be related to copper depigmentations. Now I will quiz you with another picture which looks like similar. Like this is a 74-year-old woman with no significant past medical history who presented with a nail discoloration for 5 years. The discoloration began on her right thumb and progressed to involve all 10 fingernails, sparing the toenails. The patient stated she has been using a variety of natural supplements for decades, but denied taking any medications. Examination of the nails revealed longitudinal ridging and non-blanching bluish-gray pigmentation of the proximal nail bed following the shape of the linula. Examination of the skin, oral, and ocular mucosa was negative for depigmentation. No organomegaly, no organomegaly, neuropsychiatric dysfunction, or ocular rings were identified. So my question to you, what is the diagnosis? Now I have confused you with the picture that we just showed a little earlier, azure linula. Looks very similar, but this is not azure linula or Wilson's disease. This is 74-year-old patients. Okay, so this is called as chromonychia, and occurs in silver poison or argyria. And this particular patient was using natural supplements with a high amount of silver in it, and that led to this particular type of discoloration. So I think it is important to know this differential diagnosis that may not be specific to liver disease, but when you see azure linula thinking about Wilson's disease, you got to have distinguished them from the other conditions as well, which looks pretty similar. Merkes bands, which is apparent leukonychia striata, is associated with hypoalbuminemia. Now you see this period of malnutrition. So especially in patients cirrhosis can have this kind of Merkes line. But the thing about this is these are possibly vascular compression within the nail bed as a result of local edema. They disappear when pressure is applied to the nail. That's important. When these lines are white, but they disappear, become pink when you apply pressure to the nail bed, and that distinguishes Merkes. This blanching underlying the nail bed distinguishes them from the true leukonychia striata, such as the Mies line. And I'm going to show what's the Mies line, which looks similar when we just overall look at, but if we do the blanching, apply the pressure, this disappear, the Merkes bands disappear, but the Mies line does not disappear. And this is what is a Mies line, something also called as Aldridge's Mies line, also called, and this discoloration occurs in the fingers and toes, that typically white bands traversing the width of the nail. As the nail grows, they move towards the end and finally disappear when trimmed. The causes of these are periods of arsenic poisoning. There also has been reported in thallium and other heavy metal poisoning as well, but also seen in renal failure chemotherapy patients as well. It is important to know this differential diagnosis when you're looking into the nails. Koilonychia or spoon nails, very commonly seen in iron deficiency anemia. But it is also reported in 50% of patients with hemochromatosis where there is an iron overload, right? Hemochromatosis is an iron overload situation, but 50% patients has been reported to have koilonychia. Pathophysiology is very poorly understood. Postulated mechanisms is related to the dysfunction of the metal enzymes and vasculopathy. I would refer to the reference that I have to go through more details to understand the pathophysiology or mechanisms underlying this. Splinter hemorrhages. You can see these are non-specific, but in patients with cirrhosis, you can have coagulopathy, can lead to splinter hemorrhages, and may be related to the severity of their liver disease. Now I'll go a little bit further in patients with primary biliary cirrhosis. Now these are autoimmune liver disease, and many of these autoimmune liver disease can have Raynaud's phenomenon and different other conditions. But this is a study that actually looked into PBC and they examined the nail for capillary loops. You can see in the figure A, what you're seeing, the normal capillary loops. You see the cuticle on the top and the capillary loops, which are so uniformly distributed. In the figure B, you have dilation and dropout of the capillaries. So you see the dilation of the dark capillaries, and there are areas of blanching, which is a dropout of the capillaries. So this can be these are some findings that you can see in primary biliary cirrhosis. Now let's see how important is this finding. Now this is capillaries. This can be examined by capillaroscopy, and you can see there are 4 degrees of this changes in the capillary beds that you can see: normal, mild, moderate, and severe. As you can see, particularly severe form, you see the dilated capillaries. Here there are not many areas of avascularity, but there is that, you can see that as well. But what you can see, comparing PBC with the non-PBC related liver disease, 70 patients and 57 patients, what the authors have noted is that the abnormal findings are quite common, 54% in PBC patients compared to only 14% in non-PBC liver disease. So I think that's an important sign of the liver disease in PBC, and the significance of it is not very clear. Does it correlate to the severity of liver disease? We do not have a lot of information about it, but again, could be an area of research. Common nail changes in patients with hepatitis B and C. You can see longitudinal striation in hepatitis C, as you see in the figure left side, and onychomycosis. These are also seen in patients with hepatitis B and C patients. Capillaroscopy in patients with hepatitis B and C has also shown avascular area of enlargement, blanching capillaries, capillary enlargement, and capillary tortuosity, and splinter hemorrhages depending on the severity of liver disease. Systemic sarcoidosis, you can see nail dystrophy, periungual discolorations. So sarcoidosis, which presents with the granulomatous hepatitis in many times. So if there is systemic sarcoidosis, that is involvement of the liver and multiple organs, you could have nail changes that may be present related to sarcoidosis. So also if you see on this is not that common, but associated cystic changes in the distal phalanx also is seen in these patients. Cloving is also important finding in patients with cirrhosis, particularly alcoholic cirrhosis. You see on the X-ray there's a soft tissue changes on the X-ray of the terminal phalanges. This was not from a particular patient with cirrhosis, but I presented as an example of what it looks like on X-ray. Now shifting our gear a little bit towards the hair changes in cirrhosis. Now pubic hair patterns. You see on the left side of the figure, we have the male distribution of the hair in the pubic area and the female distribution area of the pubic hair on the right side. So this particularly in patients with cirrhosis, there is a change from the male to the female patterns. So the loss of forearm, axillary, and pubic hair in both cases. And males particularly, there's a decrease in the growth rate of the facial hair, the development of female pubic hair pattern, loss of truncal hair, and flattening of the superior aspect of the pubic hair. So this is something that you can see in patient cirrhosis as they advance their liver disease. Alopecia can be a link to autoimmune liver disease found in some proportion of the patient with autoimmune hepatitis, and could be a link to underlying autoimmune liver disease or systemic autoimmune diseases. And I think it's important to look for these findings. Moderators. Moderators is the loss of eyebrows and eyelashes. These are not specific for liver disease, but could be potential manifestation to malnutrition. And patients with cirrhosis are often had a severe malnutrition, and also can be seen in patients with autoimmune disorders, especially alopecia areata. So something to look for, and something to know that moderators is a finding that is possible in patients with cirrhosis with severe malnutrition. Another sign that I would like to point out is the flag sign. Flag sign, when there is a period of malnutrition, the hair get depigmented and discolored. And you can see in particular in alcoholics when they goes weeks sometimes without eating much, and I will just depending on alcohol, and people could go severe periods of malnutrition and leading to depigmentation of the hair. And then when they have a better nutrition, that comes back with a normal color, and you can see this flag sign. Finally, I would like to close with this final slide, which is a summary of the mucocutaneous manifestation of common vitamin deficiencies in liver disease. So you can see all these different vitamins could be deficient in patients with cirrhosis of the liver, with advanced liver disease. And they not only present with cutaneous manifestation, but also with nail and hair manifestations as well. And something to keep in mind. And that's all about my presentation today. And I hope you learn. Thank you so much.
Well, thank you very much. Wonderful talk by the Dr. Satapathy. He's also on the East Coast of the United States, so that's why we cannot communicate with him. But I think there are some questions from the audience regarding the vascular spiders, spider angioma. Then the question is, the extent of the spider angioma means something, not just the presence or absence, but the number of the spiders or the size of the spiders can correlate with etiology or significance of the extent of the liver disease advancement. Is any of the panel can answer the questions? There is the question, several questions of the spider, vascular spiders. How's the Shiv Sarin? Could you answer the questions? When you see the spiders, extent or spread of spiders or number of spiders means something to you.
Thank you, and I wish Dr. Bernstein could answer this, but I can give you from my experience, they are present in pregnant females in the normal, but if they are transitory, but if the spiders are present, they are generally related to a very vasodilated system, and the number of spiders correlates with the severity of disease, with the levels of tumor necrosis factor. They also correlate with portal hypertensive gastropathy. So if you don't want to do an endoscopy and you want to speculate that, let's say if there are more than 5 spiders, this patient would have a severe portal hypertension, very high inflammatory state of TNF, maybe gastropathy. So I think it's a mark of very severe disease.
Thank you very much for the very scientific answers. Very much. How about the ages? There is some question about the ages, especially the pediatrics. And does palmarisema develop in the patients with ages under may say 10 years of age or 15 years of age? How about that kind of questions? Because we are only seeing those adults, but younger ones, do you have the vascular spiders or do you have the palmaesemas? How's that?
Maybe
Is
we have Dr. Seema
is she
there.
around?
Seema?
Yeah, yeah. Seema Alam, Dr. Seema
Yes, sir.
Alam.
Yes, sir.
Yes,
Uh,
yes. Could you answer the questions about the children? Spiders, palmarisema.
Can somebody read out the questions to me? Which one is this? Which one?
Actually, the Q&A, cutoff age, the beyond which palmar and plantar erythema can be definitely commented upon in the pediatric age group. I think that's a question to you.
Where is it written? I can't read it myself. I can't see. So where is it in the question answer? Okay.
How often you see the
Plantar
palmarisema?
erythema can be definitely commented upon the pediatric age group. Okay, so pediatric. So as far as the plantar and the palmar erythema is concerned, we only see for plantar erythema in infants. Once the children start walking, they don't get plantar erythema. They usually get only palmar erythemas. So it's only infants who get a plantar erythema, and it's very commonly seen that if you have an infant with, cirrhosis, then he will get both palmar as well as plantar erythema.
Thank you very much. Wonderful comment from India.
I can add a small part to this. When the patients become very hyperdynamic, you can see what we call a solar erythema, the sole of the foot. And solar or plantar erythema is the more advanced stage of palmar erythema seen in adults. So it is exactly what Dr. Seema said. It is the reverse.
All right.
Thank you.
So now the Shiv Sarin, could you take care of the rest of the speakers and
Thank you.
finish up?
Thank you, Professor Omata. For me also, it was a very good learning going back to the school. And I want to thank Professor Manoj. I hope he is around. He is the one who, as Associate Dean with me, has helped develop this program. Now I have the pleasure of inviting our next speaker, Professor Jasmohan Bajaj. Most people know his outstanding work in the field of hepatic encephalopathy and minimal hepatic encephalopathy. He's a full professor at Richmond, Virginia, Commonwealth University, and a very prolific writer. Let's go on to what he would like to say on neurological examination in liver diseases. Professor Jasmohan Bajaj. I hope he has a recorded thing. It's too early for them. Yes, yes.
Thank you, APASL, for the opportunity to present the neurological exam in cirrhosis and liver disease. My name is Jasmohan Bajaj. I'm Professor of Medicine in the Division of Gastroenterology, Hepatology, and Nutrition in Virginia Commonwealth University and the Central Virginia Veterans Healthcare System in Richmond, in Virginia, in the United States. So what is the goals of neurological exam in cirrhosis and in liver disease? First is to define causes or the extent of altered mental status, because that will help us determine the level of monitoring required. We also want to find out if there's any other non-liver related causes of changes in neurological status, and to see if specialized neurological, neurosurgical intervention is required, or we need some more in-depth neurological evaluation by people who have much more expertise in this than your typical neurologists would, typical hepatologists would. So what are the neurological presentations of liver diseases? I'm going to stick to primarily people with cirrhosis. I'm not going to talk too much about people with Wilson disease and things like that who have their own neuropsychiatric presentations. So you could encounter altered mental status, which could be delirium or a dementia-like state, or stuff, or a situation that actually waxes and wanes between them. People who have primarily neuromuscular issues, extrapyramidal signs, neuropathy, and myelopathy. So what are the components of a typical neurological exam? This is what we were taught in medical school, and this can be as extensive or as cursory as you can possibly think. The deeper you go, the more issues you're going to find. But the question is how to translate that into something that bridges practicality versus things that give you information that might be relevant to the patient and not necessarily extraneous. So the 6 things that are typically done are consciousness and higher mental function testing, cranial nerve examination, deep tendon reflexes, gait and coordination, including cerebellar signs, muscle bulk and tone, and sensation, sharp, soft, proprioception, temperature, and vibratory. In this, the 2 important things that are in red are consciousness and higher mental function testing, which go into deep, which are very important in patients with liver disease, with and without cirrhosis, and gait and coordination, including cerebellar signs. Cranial nerve examination, while important, are not really that useful in patients with cirrhosis. However, to exclude other causes of altered mental status, such as a stroke or people with head trauma, etc., it may be very useful. So it's important for you to keep this in the back of the mind. Deep tendon reflexes in most patients with cirrhosis are hyperreflexic. If they're hyporeflexic, they may add something else, that there's something else going on. But typically, these patients have hyperreflexia. What about muscle bulk and tone? That's typically lower in these patients because of sarcopenia, but tone really is not that affected unless there's something else going on. Sensation is usually affected in people with neuropathy, which coexists in these patients with alcohol-associated or other neuropathic conditions. But by far, consciousness, higher mental function, gait and coordination, and specific other conditions that are related to myelopathy and neuropathy may be relevant in these patients. So assessing consciousness, this is not something that is specific to hepatic encephalopathy or liver disease, but really is the Glasgow Coma Scale. If you look at the left-hand side, eye-opening, best verbal response, and best motor response. This tells you whether this person belongs into a monitored care setting in ICU, because what you want is to avoid aspiration pneumonia and these patients' airway to be safe. On the right-hand side is the continuum from hepatic encephalopathy, from minimal to psychomotor slowing, to disorientation, to somnolence and stupor in grade 3 and 4, and grade 4, which is coma. Attention goes down and arousal also goes down. Remember, the attention span decreases way before the consciousness goes down, and therefore it is very important for us to realize that first things to be assessed is the consciousness, not only to find out what tests to use further, but also to see where to get this patient, where the patient should be transferred. So this is the West Haven criteria, and in these patients, minimal and grade 1 hepatic encephalopathy. Now, Dr. Ferenci is going to cover minimal encephalopathy a little bit later, so I'm not going to go into the details. These are the patients who are unimpaired, are patients with no encephalopathy, no HE history, and currently completely alert and oriented. Minimal is the patients who get these specialized tests, are abnormal on that compared to age, gender, and education matched healthy controls from the same community, then that is minimal age encephalopathy. More importantly, they have no clinical evidence of mental change. Grade 1 is a big sticking point because look at the trivial lack of awareness, euphoria, anxiety, shortened attention span, impairment of addition, subtraction, and altered sleep rhythm. These are relatively soft indicators, and unless you know the patient very well, or the patient's caregiver gives you additional information, it is really very difficult to operationalize grade 1 in multi-center studies. So it may be important for clinical assessment, but may not be relevant for multi-center approaches. What about, this is how things would behave. What about grade 2, 3, and 4? Grade 2 has lethargy or apathy, disorientation for time, asterixis, inappropriate behavior, dyspraxia. Again, in this, disorientation for time and asterixis are relatively stable, and we're going to talk a little bit about asterixis a little bit later. Then you have somnolence and semi-stupor, gross disorientation, which means disorientation of place and person as well. The patient is confused, but is available to be responsive to stimuli, and there could be some bizarre behavior. And grade 4 is coma. And how do you operationalize this? Disorientation from time in grade 2, disorientation for space and person, and other symptoms that we talked about, and of course, patients who do not respond to painful stimuli at grade 4. So here it is quite easy to see that grade 2, 3, and 4 have very good interpersonal ability to be reproducibility. And this was formally tested across 7 centers in the United States and Canada, and where we gave standardized videos. And you can see grade 2 or higher, the agreement was more than 90%, regardless whether people were trainees, non-trainees, or both. Less than grade 2, you can see it's 60%. And this goes with normal grade 1, grade 2, grade 3, and grade 4, which tells you that grade 2, 3, and 4 is where there is much more agreement. And this is usually what is called overt hepatic encephalopathy when you talk about multi-center studies. So therefore, because MHE and grade 1 are very difficult to diagnose clinically, they are usually labeled as covert if need be, and overt is grade 2, 3, and 4 in these patients. So how do you approach a patient with potential encephalopathy? You have disorientation, asterixis, somnolence, stupor, lethargy, or coma. If yes, this person clearly has overt hepatic encephalopathy. If no, then you look at the setting of assessment. Is it clinical practice, a single center trial? If yes, do you know the patient well, or do you have caregiver input? If you know the patient well, or the caregiver says something is abnormal, then you treat the patient as OHE, because you have decided there is something wrong with this person, and the caregiver thinks there's something wrong with this person, then go ahead and you can treat the patient as overt HE. However, if the patients, are not familiar with the patient, and you do not have any caregiver telling you that there's something wrong, you can consider some specialized testing, as potentially Dr. Ferenci is going to talk about in the next talk. When you look at multi-center trials, however, you really need to focus on grade 2 and higher for overt encephalopathy because of the very soft endpoints that are in grade 1. And you do not want a drug that is working to be not approved, or versus a drug that is not working to be approved because the endpoints were not stable. Of note, regulatory agencies in the United States do not accept grade 1 as an endpoint anymore. And the West Haven criteria has to be finessed before these drug companies, these regulatory agencies such as the FDA, will accept these as endpoints. So what about in a patient with cirrhosis who comes to you and has confusion, but you're not 100% sure that this is encephalopathy? What are the clues against this being encephalopathy? New focal deficits are clearly not typical for encephalopathy. They may be much more likely to happen in stroke, head trauma, or other places that can cause focal deficits. And stroke and head trauma are really very important in our patients because of the obesity epidemic. These patients also have severe cardiovascular issues that can cause stroke. Head trauma in patients who are frail and have problems with coordination could have hit their head a while ago and could have a subdural hematoma. So if a new focal deficit appears, this is something we need to be very worried about. Excitatory motor activity, especially seizures, are very rare in patients with cirrhosis and hepatic encephalopathy. They may be common in patients with acute liver failure and in people with urea cycle disorders. But otherwise, you must think of other causes such as toxins and alcohol withdrawal. Current recent alcohol use, current recent illegal or legal sedating drug use, because many of these patients have problems in which they are having problems sleeping, so they sometimes are prescribed or take over-the-counter medicines to make them sleepy. This can cause an encephalopathy, but it's not necessarily hepatic encephalopathy. Alcohol use, of course, can be several syndromes that range all the way from Wernicke's to Korsakoff's, all the way through alcohol withdrawal, alcohol intoxication, etc. So it's very important for us to take a nice history, both from the patients and the caregivers, about the alcohol and the temporal nature of their altered mental status presentation. And of course, other situations in which HE is unlikely. A patient with cirrhosis can also land into situations that are maybe in which HE is not likely. And so therefore, we have to make sure that we don't overdiagnose HE in a patient who may have other issues going on. So now you've figured out that the patient is conscious, the patient is able to do things. But then the question is this patient suitable for cognitive analyses, which require a lot more investigation? So which means the patient has to remember what those tests are, has to remember how to do them. So it is very important for us to figure out further. The two things that have been used in the past, mini-mental status, are the Montreal Cognitive Assessment, MoCA and MMSE. These have been used in the past to define whether someone has cognitive impairment or not, with and without hepatic encephalopathy. And there is also the animal naming test, which has been used for covert hepatic encephalopathy, that I'm sure Dr. Ferenci is going to talk about. So I'm not going to go over that in detail. But clearly, if a patient is awake, you want to make sure before giving them the battery of cognitive tests that they're able to handle it. And scores above 25 on this is something that we usually use in our practice and has been published before. So moving on to asterixis. Asterixis, as we know, is the flapping tremor that is really found in patients with encephalopathy and which we often use as a reason to diagnose encephalopathy. It is through thalamo-cortical coupling. In this nice study, you can see that this is an oscillatory network that goes between this, which causes the voluntary movement to the patients to actually stop having the voluntary movements. And some people have graded, Dr. Korn graded this as grade 0, 1, 2, and 3. And you can see these are the number of flaps per 30 seconds. As you would imagine, the greater the number of flaps, the worse off the patient is going to be. However, is this specific for encephalopathy? No. It is not specific, but it's often found. So you can find in liver failure, in azotemia, and respiratory failure. So CO2 narcosis as well as uremia, which can often coexist with encephalopathy, can cause this. Bilateral brain dysfunction, etc., and many other drugs can also cause this or make this likely to happen. More importantly, bilateral asterixis is what is found in cirrhosis. Unilateral asterixis, as we said, focal deficits are not something that is typical of patients with cirrhosis. So if a patient has unilateral asterixis, please think of something else, which is a focal brain lesion. So again, asterixis is often used in the classification of hepatic encephalopathy, but it should not be the only thing driving you to diagnose encephalopathy in a patient who could have many other reasons for it. What about gait and station? It is very important for us to predict falls in these patients because these patients are often sarcopenics, have problems with coordination. And when someone also has hyponatremia, in addition to that, this thing becomes even worse. So the best and easiest way to test this is a tandem gait. In a patient walks a straight line while touching the heel of one foot in front of the other, and this also tests cerebellar function. It is very important when you're doing this to make sure that the patient does not fall. So there should be adequate protection, a person standing behind and the person standing in front. In our experience, we have found this to actually predict falls, and this gets better after the patient gets transplanted. So it is associated with falls pre-transplant and can be associated with the improvement after transplant. Hopping on one foot, not really preferred. Romberg, you can ask the patient to stand with their feet together, touching each other, and see that they actually fall or not. And this actually is a very dangerous test, and we very rarely use it. But tandem gait is something very important. Other cerebellar signs, such as dysdiadochokinesia, etc., can also be done. But typically, the one that gives us the best information in the least amount of time is tandem gait. You can also do things such as the 6-minute walk test and the get up and go test. Again, those things check coordination as well as speed, and will tell us in a very short time whether this person is likely to fall or not, which is a very important endpoint in these patients. What about the rare situations, such as hepatic myelopathy? It's important to realize that hepatic myelopathy is largely independent of patients with hepatic encephalopathy. This can happen with and without encephalopathy. In extremely rare conditions, it can happen as their first episode, present neurological presentation. It is a spastic paraparesis. What it means is the bilateral lower limbs are spastic, and this is motor. There is no sensory, bladder, or bowel involvement, and there is hyperreflexia, as you would expect in patients with cirrhosis. No other cause of myelopathy should actually be apparent. So basically, you have to make sure, do your due diligence and make sure there is nothing else going on. And this can sometimes be improved after transplant. And this is the evoked potential, motor evoked potential of a healthy person. This is before transplant. This is after transplant and later after transplant in this nice series done by Dr. Weisenborn. So it is important to keep this in mind. It's a very rare patient, but when you find this patient, it is important for you to diagnose it correctly. What about extrapyramidal symptoms or Parkinsonian-like symptoms? There is a group of patients who have this acquired hepatolenticular degeneration, which is actually very different from idiopathic Parkinson's disease. In patients with cirrhosis who have this, these are typically patients who have had multiple episodes of encephalopathy, who could have a lot of manganese deposition in the brain. This is related to rapid progression, early postural and gait problems, symmetric disease, and decreased proportion of patients with the classic pill rolling tremor. So again, compared to idiopathic Parkinson's disease, these patients are much more likely to have these situations. And this is because of pre and post synaptic alteration of striatal dopaminergic neurotransmission, as shown in this nice study done in 2012. But what it tells you, that this is something that may or may not be completely resolved after liver transplantation. If you find this, this may actually potentially get better with levodopa, but you want to actually diagnose this, and this may or may not be associated with associated hepatic encephalopathy in these patients. What about neuropathy? Neuropathy in these patients are greater in those with alcohol-related cirrhosis. In this review done across multiple centers and multiple groups, the prevalence is ranges from 18% to 53%. These are typically axonal sensory motor polyneuropathy, not really specifically related to HE severity or presence of encephalopathy. So you can see now the patients with cirrhosis, even patients with cirrhosis, have so many other issues that are going on that range from sensorium all the way to peripheral as well as the myelopathy that can actually make the neurological exam very important in these patients. So in this day and age of regular CAT scans and MRIs taking the place of physical exam, the role of the neurological exam in defining the presence and severity of cirrhosis or liver disease related neurological abnormalities remains very important. Here is further reading, and I thank you all for your time.
Thank you, Dr. Bajaj. I'm not sure. Oh, you are online, is that right? Very nice to see you, Dr. Bajaj, and thank you for a very outstanding talk. Maybe I will take the questions after Professor Peter Ferenci's talk. Is Professor Ferenci available online, I guess? He is very punctual and is always around. Yes, Peter, are you around? For the benefit of others, Professor Peter Ferenci is one of the finest clinicians and had held the position of holding the World Gastroenterology Organization and holding its meeting. He was instrumental in Austria in setting up one of the finest departments, and is still very active. He has done a lot of work on hepatitis C and has also a huge amount of experience in hepatic encephalopathy. I would like to invite him to give this talk on assessment of minimal hepatic encephalopathy in patients with liver disease. If not, the APASL Secretariat may run the video, please.
Good afternoon. My task today is to discuss with you minimal hepatic encephalopathy. The definition of minimal hepatic encephalopathy is a condition without obvious clinical manifestation and characterized by neurocognitive impairment in attention, vigilance, and integrative function. This is the rather complex classification of hepatic encephalopathy. I just concentrate on type C, hepatic encephalopathy, which means the encephalopathy which occurs in patients with cirrhosis and portal hypertension and portal systemic shunts. You can subdivide it further in episodic, persistent, and minimal hepatic encephalopathy. Episodic means that it's precipitated, goes away spontaneously, and may recur. Minimal hepatic encephalopathy is the topic I'm going to discuss with you today. Now, you wouldn't believe that the authors of the guidelines discussed almost 3 years about this graph. Basically, you have here the grade of encephalopathy, which is 1 to 4, according to very well-defined clinical characteristics. And then you have here minimal hepatic encephalopathy. For the clinical business, you frequently combine covert MH1 as covert encephalopathy as opposed to overt, easily clinically diagnosable hepatic encephalopathy. And you see this distinction again, this error goes from normal to highly abnormal in coma. And you have a during this time, patients or the people who have unimpaired psychomotor function. Then you have patients where you can detect some form of dysfunction by doing psychometric tests. And then you have overt stages of encephalopathy shown in yellow. And there's an over term between grade 1 and minimal hepatic encephalopathy. People use also the term covert encephalopathy. The categorization is often arbitrary and varies between raters, so it's really test dependent and rater dependent. The important points about these different types are very clear. In unimpaired patients, mental status is normal, tests give you normal results, and they have no asterixis. In patients with covert hepatic encephalopathy, which includes minimal hepatic encephalopathy and stage 1 encephalopathy, mental status is not impaired. Tests show abnormities, and that's the definition of it, and there's no asterixis. And in patients with overt hepatic encephalopathy, they have obvious symptoms from disorientation through coma. They may be able to do specialized tests. If they do so, they are abnormal, and asterixis is present except in coma. Now, what is important for a human being in daily life, which can be impaired in hepatic encephalopathy, is first memory, working memory to remember things on a short-term basis, inhibitory control, to inhibit a response when the question or the task is not accurate, problem solving by itself is important for your life to make clear-cut plans for your life. Reaction time is very important when you are driving or working. The same is true for psychomotoric speed. If you work on a machine or drive a car. Then I come back to immediate memory to remember things over a few minutes. The thing you do is tell them a 4-digit number and ask them 5 minutes later what the number was. Then visual motor coordination, again, very important for all tasks like navigation, driving, working, drawing, and so on. Speech and language and delayed memory are long-term problems. So to test for minimal hepatic encephalopathy, there are 4 important points to remember. The test should be valid. It means it should represent the neuropsychiatric abnormalities present in hepatic encephalopathy. There should be objective. The test procedure, evaluation, interpretation must be standardized and thus independent from the tester. It should be reliable, that repeated measures of subject with clinically stable status provide similar results, and there should be some sensitivity and specificity to separate patients with manifest AG, minimal AG from healthy controls. Now, there are many problems which you should address in testing for psychometrics. First, education is important. If you're illiterate, you cannot recognize letters very well. Visual fitness is very important if the vision is a part of your task. The testing conditions you set up for the patients is important. It should be a calm environment. The duration of the test should be rather short, otherwise the tested person gets tired. Food intake may play a role if, for example, you have an increase in ammonia. And always an important point is a test available or not? The very simplest test, which bypasses all of these problems, is the animal naming test. In this case, the patient is asked to name as many animals as possible within 60 seconds. And you have 3 scores then. If it's less than 10, 1 if it's 10 within 15, and 2 if it's greater 15. And what you can see that these people who can name more than 15 animals Most of them are normal, 80%. Very few have minimal hepatic encephalopathy and negligible in severe stages. Exactly the contrast are people with a score below 10, only 20% are normal, and most of them have over HE. This test also predicts a little bit the likelihood to have a new attack of hepatic encephalopathy. This is score null. The likelihood is almost 40% that they get 60% that they get HE, as compared to score 2, where it only occurs in 35%. These are other test systems for measuring hepatic encephalopathy, minimal hepatic encephalopathy. The most common are the paper pencil tests, the PHES test, and the critical flicker frequency using this machine. And there are many other psychometric tests which I'm going to show in a moment. Basically, use what you have. You cannot do everything, it takes too long. And you have to really define whether you just screen for encephalopathy or whether you have a patient with encephalopathy who is on treatment and you want to see the effect of treatment. This is the simplest of all tests, number connection tests. You connect these numbers, measure the time it takes and the number of mistakes, and there are scales where you can read the importance of the results. The normal is 60 seconds to upper normal to complete this task. Again, tiredness is a very important limitation for this test. This is critical frequency. Basically, what you measure, there is an instrument which gives you light at various frequencies in hertz. And at a given frequency, you don't see the flickering, you just see one picture. And that's the critical flicker frequency. And you see in controls, it's around 43 hertz. TV set works at 50 hertz. You see here that in minimal hepatic encephalopathy, there's a minimal impairment, and it goes on, it gets worse and worse with increasing stages of encephalopathy. Limitation for this test is beyond the equipment. Your vision has to be normal. This is another test where you can measure psychomotor vigilance. Basically, you see numbers appearing here, and if the number appears, the patient has to press a button, depending whether he's left-handed or right-handed. And then you can measure the time here it takes to see the number and respond to it. And for example, to look for driving capacity, you can use this test. You see here different types, patients, no license, no driving. So license and driving, license, no driving, and a very bad group, no license but driving. And you see here they are doing very poor. This is a test developed by Bajaj, who just gave you a lecture. It's available as on the PC, on your handy. The Stroop test, basically what it does, it shows you something in a color, and you have to touch the right color. So you see it's blue. Or it shows you a writing. You see here, it's green, but the correct color is blue. So it's really a very important test. You cannot press green in them in this case. And that's the test result you get. It took you 5.9 seconds to do this task. And you see a variety of combinations, both in writing and in color. For example, red can be red or written in blue and so on. So it's all random as it comes up, and you can very nicely test the patient's concentration and capacity to react. An important point is the specificity of psychometric tests. You see here one study where they looked for the standard paper pencil tests. You see here the performance in normal persons and in patients with heart failure, end-stage renal failure, type 2 diabetes, and obstructive pulmonary disease. You see they are also slightly abnormal. So it's not specific for hepatic encephalopathy. So if a patient has multiple conditions, these tests have a problem for interpretation. Sickness impact profile is a questionnaire which is used for a long time in hepatic encephalopathy. This is now a new score, which is the sickness impact profile questionnaire for covert AGs, SIPCHE. And it consists of only 4 selected items of the sickness profile, gender and age. And there are 2 measures to define MEG, like the continuous reaction times and the PSE syndrome test. And what if, this is a very old paper on the sickness impact profile. You see here the reference population, healthy people, patient with cirrhosis without minimal encephalopathy, and then you see here patient with cirrhosis and minimal encephalopathy. You see here, for example, alertness, work conditions, sleeping, and recreation are the most abnormal parts of this SIP score and can be selected. And if you do the SIPCHE, you can see if you had no minimal hepatic encephalopathy according to psychometry, still 24 had a, I'm sorry about this, still 24 had signs of abnormal SIPCHE. If the minimal hepatic encephalopathy was present, 58 had also abnormal SIPCHE. This gives you a sensitivity and a high sensitivity but a low specificity for these tests. Then you have the inhibition control test. In this case, you should not respond if the thing is wrong. So you inhibit responses. Again, measure the time and the number of Lewis where you made a mistake. And you see here, for example, patients without encephalopathy and patients with minimal hepatic encephalopathy, the number of mistakes they make increases over quite dramatically. And it's also a very good test, therefore, to measure their functional brain situation. And you see here the ROC curve, which is almost 100.9 and has a very high specificity. And to end and summarize, basically what you want to do is to test from normal function to coma, and somewhere in between is minimal hepatic encephalopathy. You can test for executive functions, but it's different tests. The psychometric AE score, inhibitory control test. For vigilance, you can again test a variety of tests. Again, basically the inhibitory control test and the psychometric AG score. Reaction times, we have the number connection test, the digit symbol test. These are the tests which separates you from deep problems and overt AG, where you can alertness and orientation, a variety of clinical scales, but you don't need all this psychometric testing. So I hope I gave you some overview about hepatic encephalopathy testing for mild cases. I could not really discuss all available tests, but they're very nice reviews. I can recommend you. Thank you very much.
Well, thank you very much. And it's a pleasure that the first session of the clinical science in liver diseases was very well attended. I can see Professor Jasmohan Bajaj very well. And can other panelists, is Professor Peter Ferenci around by any chance? Online? If not, I will go to some questions which have been asked, and first is to Professor Bajaj is distinction between dyspareuxia, apraxia, and asterexis.
So dyspraxia is actually a trouble with movement. It's a general trouble with movement which spans fine motor skills, gross motor skills, planning and coordination. So and whereas asterixis is a kind of a tremor. So that's the big difference. Dyspraxia is kind of a basket case, a basket term. We put everything, the coordination changes, the handwriting changes that sometimes happen in patients with liver disease, and including things that they can't sometimes, if they're trying to we've had people who actually tried almost cut off their fingers because their visual motor coordination was not the same. All of that falls into the dyspraxia picture. That word is not very widely used because it's a very because it's not very specific when it comes to our patients, and our patients have so many other subparts of that require additional testing.
Another question to you is about the hepatic demyelination syndromes, where you say it is only paraparesis. Can it not be quadriparesis?
I tried to, everything can be anything. I mean, if you look at the rare situations, I tried to focus in my talk only things that you may actually encounter because it's e-learning. I wanted to not go too much into esoterics. If you find a patient with hepatic myelopathy, you should really buy a lottery ticket that day. You really should. Even that is so rare to find even if people who've been at it for a long time. So things that are even rarer, I stayed away from. If you go to the literature, you will find almost every single thing that can be attributed to liver disease has been attributed, whether it's pre-cirrhosis, post-cirrhosis, post-transplant, peri-transplant. So I just tried to focus on the things that are you would likely to see in your clinical practice.
Just for benefit of some, because we had seen these when linorenal shunts were very common. Yeah. So patients who had linorenal shunt, they would end up after some time with something like monoparesis, quadriparesis, paraparesis. And this also used to be called as shunt-induced myelopathy to some extent, but now it is rare. And you do not see it that often with a spontaneous shunt, but nevertheless.
Yeah, and not even after TIPS, you don't see it after TIPS.
Yeah, you don't see it.
It's very rare that you actually end up seeing this.
And now another question is, how do you differentiate between HE and alcohol withdrawal?
Sometimes you have to go with your gut and see what's happening with the patient, and that's why you have to play detective. Many patients will not tell you that they've been drinking. You have to call and talk to literally everyone who's been in touch with the patient. Use your clinical judgment, but if a patient has seizure, it's highly unlikely to be encephalopathy. The more important question to me, and the tremulousness is very different from asterixis. So if someone is just like shaking but doesn't have that flap, that is not really asterixis. It's actually tremulousness because of potential the shakes that they get after withdrawal. What we want to be very careful about at this stage is the treatment for one may worsen the other. So you want to look at, if you're giving benzodiazepines, which actually may worsen encephalopathy, you have to get back and see what is going to kill the patient first. It's the delirium tremens is going to kill the patient first. So you really want to actually treat the alcohol withdrawal if it is severe enough using your local protocols or the CIWA protocols, because if that is left unchecked, the encephalopathy you can fix. You can actually make sure that the drugs are washed off the system, the patient gets airway protection while you're doing all of that. So to me, the more important thing is when you're suspecting both, err on the side of thinking it is alcohol withdrawal after you've gotten some confirmatory signs. And as I said, and people have said before, this is only one part of your full assessment, the global assessment of the patient. You cannot make a diagnosis of alcohol withdrawal if the patient has never been drinking in their lives. So you really obviously have to have a thorough history and not just rely on physical exam. The physical exam is only one part of the big picture that makes you be a full detective for the patient.
One more question to you. Should we do nerve conduction study as a routine in patients with AUD?
That's a very important question, and typically we don't at least in the United States, we don't do it very often because unless the patient has debilitating issues. So if they have debilitating issues, we actually do send them to a special neurologist, because what we may think is alcohol used a related neuropathy may be something completely different. So typically we again go back as to what the patient is feeling. So feeling, functioning, and surviving, those are the three things we always want to go back to. Is the patient is complaining of pins and needles pains, at the zipping pain, or not being able to feel the bottom of their soles, clearly you want to treat them first with multivitamins, thiamine, and make them stop drinking if they are not. But if this still does not get better, then clearly it requires something that a neurologist might do. But again, as I said before my talk, neurological exam, you can go as deep as you want. You will always find something. The question is, if the person has NCV abnormalities, but is not feeling anything, is there's nothing wrong, the patient does not think that that's part of the 50 million things that else is going wrong with them. What are you going to do with that information is what you want to be very important. So before you pull the trigger on any of these very expensive / invasive tests, you also want to make sure that you have a clear plan. If it is positive, what you're going to do. If it is negative, what you're going to do. And again, go back to what the patient is. If the patient is suffering, that should guide your judgment as to what to do.
Entirely agree. It's a very long topic. It's a complete neurology and dysarthria, movement disorders, you name it, and they are all very big. I would just like to add one point that we routinely use bromocriptine rather than levodopa in all our hepatic Parkinson, and it's a very rewarding drug.
You have published on that recently.
I think, yes, we had a study, and these are very useful when you are having no transplant options. Otherwise, such patients very often would end up. I look for, there are many other questions, Professor Bajaj, and I would like to, however, close it in the interest of time. This is the first of the series of clinical science in liver diseases, and I thought we have gone back to the school, learning like first year, second year medical clinical residents. All the 6 speakers gave great talks, and as I'm told, 600 people were registered, and what we see here was maximum 230, but I'm told from the APASL Secretariat that more than 400 were watching. Thank you all, and I do hope after a month, and I must thank Dr. Manoj, who had been instrumental in coordinating and getting people around. So thank you all on behalf of APASL School of Hepatology. Thank you. Hope to see you after a month. Bye-bye.
Bye.
Sanjay is there.
Very much.
Sanjay, very nice seeing you. Thank you for your capillaroscopy. There were questions on that. Although I said thank you, but would you like to answer? There was one question with you on this question has come for capillaroscopy. I saw it in the question box. Is there any, where was it?
I think while you are looking through the questions, the capillaroscopy has, particularly some of this patient that we, some of this disease, particularly autoimmune liver disease, PBC has been investigated quite a bit. We don't know really the relevance of the utilization of the PBC. This is, I think, a fact of finding that have presented. Okay, in PBC patients, we find this severe abnormalities on capillaroscopy. Whether this relates to severity of liver disease, all these things I need to investigate. This opens a Pandora's of questions. I think something that to think through, and probably we should investigate more with regards to the capillaroscopy.
Well, the question was from our past president of APASL, Diana Payawal, and she says, congrats, I enjoyed. The question, one of our boys had asked a question, a capillaroscopy, is it useful in blacks?
Well, I think it doesn't matter. I think the capillaroscope, whether the color of the skin, I think on a microscopic level with the capillaroscope, you can absolutely see it doesn't matter the skin color.
Okay. All right, you gave us very good talk, Dr. Satapathy, both on the nail and the cutaneous. And we do hope to have you engaged with APASL as always. Thank you for joining us. Have a great day.
Thank you for the kind invitation.
Thanks.
Thank you, everybody. Good night.
Masao, are you still there? Are you in the medical school now?
Yeah, I go to bed. Yeah, it's about 10 o'clock. Bye-bye, everybody.
Bye-bye.
Yes, good night.
Bye.
Bye-bye. Thank you. Very enjoyable. Thank you.
I would like to take this opportunity to invite all of you to attend the APASL 2021.
Save the day.